Thank you for the nice introduction. So my topic today is psychiatric comorbidities of tinnitus, diagnosis and treatment. And I hope that I will be able to give you some overview about this topic in the next 20 minutes. So most of you might know this algorithm for diagnosis and treatment, which has been developed as an initiative of the Tinnitus Research Initiative. And today I will talk about the case history and the assessment of severity in order to identify whether there is a relevant psychiatric comorbidity, and for sure also about the management of patients with psychiatric comorbidities. So about the case history, what do I want to find out in the case history? And I want to find out how burdened is the patient by the tinnitus, what stresses the patient most, and are there relevant psychiatric comorbidities? And how do I do this? The tinnitus severity, I can skip fast because Tobias already mentioned it. It's a very easy possibility to just ask the patient about the impairment. For sure, we have all the different questionnaires. And for this purpose, for clinical purpose, it doesn't matter which questionnaire you use. What is clear, the higher the tinnitus burden, the higher the scores in the questionnaire, and the higher the risk of psychiatric comorbidity. So whenever somebody scores high in one of these questionnaires, you have a higher risk of psychiatric comorbidities. So if I know already about the amount of suffering, about the tinnitus burden of the patient, I do want to know what stresses the patient most. Why do I want to know that? First, it's most important for the patient. It's important that the patient can tell you what bothers him most. The next, it varies largely from patient to patient. So even if all suffer from tinnitus, the reason why they suffer and what makes them suffer differs from patient to patient. So the most frequent responses on this question are insomnia, the difficulties to get to sleep, concentration difficulties. Some patients just tell, it bothers me that the patient is there, or they are worried that the tinnitus might get worse, or they are really very sad about the fact that they are not able to experience quiet anymore. Some people feel exhausted. Some complain about communication difficulties, and many also complain that hyperacusis bothers them most. So it's important to know it. And why is it important? Because it's already the first step towards a therapeutic approach. If I know what bothers the patient most, I already can think about what can I offer to the patient. For example, if insomnia is the main problem of the patient, I can think about pharmacological treatment in order to reduce insomnia, and this might already provide relief for the patient. So that's a very important question that should be asked to every tinnitus patient. So now about psychiatric comorbidities, we know that tinnitus is related to many different psychiatric comorbidities, frequently depression, frequently anxiety, hyperacusis, which is also a little bit related to anxiety or phonophobia. Many patients complain about loss of concentration, exhaustion, continuous emotional stress, loss of appetite, sleep problems, a very frequent complaint, addictive disorders. It's not so frequent, but sometimes we have tinnitus also in the context of addictive disorders, and very frequently social withdrawal, also because of the communication difficulties. For sure, what frightens us most is the suicidal risk, that some tinnitus patients can be so desperate that they don't want to live anymore. And for sure, this is a red flag where everybody is concerned because of the suicidal risk. The tinnitus can become a life-threatening disorder. So that's something we also have to have in mind, that this can happen. Luckily, it's very rare, but how do I assess it, and what should I do if I identify a high risk of suicidal ideation? So a first question in order to get an idea about psychiatric comorbidities is to ask the patient, have you been in psychiatric or psychotherapeutic treatment? So you already get some idea what is going on. So I mentioned a very frequent comorbidity is depression, and the question is, how can I screen my patients for depression? So there's a very easy screening instrument which consists of two different questions. One assesses depressed mood, and the other one, anhedonia. So you can ask these questions whether the patient felt down, depressed, or hopeless, and whether he had lost interest or pleasure in doing things. If you have yes to these two questions, you have quite a high risk that there's a real depression in this patient. If no, there's low probability that the patient will suffer from depression. In case that you have yes to both, you should continue and ask about other depressive symptoms like weight change, sleep problems, psychomotoric problems, lack of energy, excessive guilt, poor concentration, suicidal ideation. And so formally, if you have the two main symptoms, the two main questions, and 5 of the other symptoms over a 2-week periods, you can diagnose a depressive disorder. What is highly relevant is the fact that the depression in tinnitus patient is sometimes a little bit different from the depression in typically depressed patients. So frequently, the core symptoms of depression are less pronounced. So our tinnitus patients suffer from insomnia, from exhaustion, from poor concentration, but their mood and their interest in things is not so much impaired. So you should be careful not to look only on the main symptoms, but also on these additional symptoms. And this is also a problem. Sometimes you realize that the patient is kind of depressed and is really exhausted and can't sleep anymore. You send the patient to the psychiatrist, and the psychiatrist says, oh, it's not a severe depression because the mood is quite okay, and also the interest in things, so there's no real anhedonia. So it's really a kind of a different symptom pattern in tinnitus patients with depression compared to the classical depression. So for sure, whenever we have a patient with psychiatric comorbidities, our concern is how is the risk for suicide. And also this, we only can find it out by asking the patient and trying to get information from the patient about the situation. And for sure, it's not so easy to ask a patient about suicidal thoughts. And one possibility is that you try to ask what's the worst thing about your tinnitus. Anyhow, you have already asked it. And what are the situations when you are bothered most by your tinnitus? And then you understand, yes, I realize that you are really terrified by the situation. Do you also experience feelings of hopelessness, or do you think that you are currently not able to go on with your life? So you already ask whether this feeling of that the patient is not anymore able to look in the future and has no perspective anymore. And then it's not a big step to asking whether the patient has ever thought about hurting himself or herself, or taking his or her life. And some patients say, yes, I thought about it, but I won't do it because of this and that. And now that's an important information. You get an idea that the patient thought about it, but definitely he will not do it. And you can trust the patient in this situation. For sure, if the patient is not able to talk further, you should ask, is this a recurrent issue? So you really have to ask it. And many people are concerned that by asking the patient about suicidal ideation, they create them. That's wrong. You never create by asking. It's only a relief for the patient that they can talk about it. So you can really ask. So if whether the patient has some ideas about taking his or her life at the moment. So you should do that. And if the patient says yes, so the next step is to try to find out, do you already have plans for that? Can you tell me about your plan in detail? Have you made attempts to commit suicide already in the past? It's a very important question. It provides the most information about the real risk of suicide. If somebody has had a suicide attempt in the past, that's a high risk patient. And then you can ask about further preparations. But if you get a yes to these answers, there's a real high risk for suicide, and you have to refer the patient to a specialist, to a clinic, because it's a life-threatening situation. You really have to act in this situation. But only here, only in the 4th step. So when the patient tells you he or she has planned. If you are on the other levels, I think it's very important to provide the patients an offer to stay in contact, to discuss what can the patient do if these thoughts get worse, where to go. But already the fact that you talk about this to the patient, so that's the most important procedure and the most important treatment at this moment. Okay, you have to consider some red flags. I already mentioned very important is suicide attempts in the past, but for sure there's also other aspects: severe psychosocial problems, psychiatric comorbidities, no therapeutic response in the past. So the patient tried lots of things, but he didn't feel any relief. Severe psychotic symptoms. So if the patient has lost the contact to reality, he's convinced that he will never get better. So that's a psychotic symptom. Social isolation, people who are alone, who have no direct social contact, they have a higher risk. And for sure, you should think about suicidal attempts in the past, or also aggressive behavior. So these are all red flags you should consider. And in this case, you also should push the patient to get to the clinic. You might encounter the situation that you see it is necessary that the patient goes to the clinic, to the psychiatric clinic, but the patient doesn't want to. So in this case, you have to force the patient. You have, according to the local regulations, and here in Germany, we also involve the police in order to bring the patient to the hospital. But typically, it's possible to recommend it, and patients go there on their own. So this was a little bit the detection about depression and about suicidal risk. I think the other frequent comorbidities are not so difficult to detect. Insomnia, you just ask a patient whether he has difficulties to get to sleep, and also whether how is the sleep over the night, whether he gets up early or whether he wakes up during the night. So you just ask about insomnia. And the next step would be anxiety. Also, it's something to ask. And you should ask about whether the anxiety is more general or whether it's focused on specific aspects, whether it's concerns or worries. You should ask about potential panic attacks and about increased tension altogether. So you get a certain feeling. And now the next step is how can I manage psychiatric comorbidities? And the first recommendation from a psychiatrist is refer the patient to a psychiatrist. But I am well aware that it's not so easy. The first difficulty is to find a psychiatrist where the patient gets an appointment. The second difficulty is to convince the patient to see a psychiatrist, because the patient thinks I'm suffering from my tinnitus. And if the patient is referred to the psychiatrist, he has sometimes the concern that the ENT, the audiologist, doesn't take the patient serious. So you have to explain that the reason that the patient should see a psychiatrist is that there's comorbidities, and it's important to treat these comorbidities in order to find some relief. So I think you have to explain it to the patient, but still, it's for many patients very difficult to find the way to a psychiatrist. And maybe even if you find a psychiatrist and the patient is willing to go there, it can happen that the psychiatrist says, "Oh, this patient suffers from tinnitus. I don't see a relevant psychiatric comorbidity." So again, it's just, I'm well aware that it's difficult. For sure, it's very well to have an established relationship to an expert in psychiatry and psychotherapy, so that also the psychiatrist has some experience with tinnitus. But in many cases, this is not possible. So the reason for that is that you will get now psychiatric training in 5 minutes. So what is important in psychiatry? Number one, number two, number three, all therapeutic relationship. You have to get in contact with the patient, and the patient has to perceive you as a partner, somebody who understands you, because that's the only chance that the patient will follow your recommendation. If the patient has the feeling that the person who sits in front of him does not understand what is his or her problem, he will not follow your recommendations, especially since no patient is very happy if he or she gets a recommendation to take some drugs, some psychopharmaca. So you have to establish a relationship that the patient feels understood and is convinced that you can help him or her. So that's the basic requirement. And then there's more or less two main therapeutic approaches in psychiatry. The first is medication, or the two are medication and psychotherapy. So concerning the therapeutic relationship, so that's very abstract. How could it look like? So you all know the situation, the patient that's there. I can't stand the tinnitus anymore. I want that the sound stops. Because of my tinnitus, I can't sleep anymore. I can't get used to it. I'm really desperate. So if the answer is, as frequently the case, sorry, there's no cure for tinnitus. You have to get used to it. You can imagine how the patient feels. The patient feels helpless and lost. But in the same situation, you also could answer, I understand, I can imagine how difficult the situation is for you. And yes, even if there exists no cure for tinnitus at the moment, there exist different treatments for reducing the tinnitus burden, and we can find a way to offer these to him and reduce your burden. So you already have established a relationship and you have provided hope. So that's the very first step to get in contact with the patient. So the next aspect, or the next therapeutic option that you have is medication. And we know that depression and anxiety can very efficiently treated with some medication. And it's not so complicated. So there's more or less two types of antidepressants. So, and you can remember practically all antidepressants also have an anxiolytic effect. So you can also use them for treatment of anxiety. And the main difference between the two classes of antidepressants, some of them are sedating and others are activating. And you can imagine if a medication is sedating, you should provide it in the evening in order to improve the sleep. If it's activating, you should offer it in the morning. And the choose whether you should choose a sedating or an activating antidepressant depends on the symptoms of the patient. If the patient is suffering from insomnia, difficulties to get to sleep, you choose a sedating antidepressant. And there's just some possibilities. Trimipramine is one of them, mirtazapine, all at a low dosage. Amitriptyline, the classical standard antidepressant, is also very helpful for chronic pain, also for tinnitus sometimes. Agomelatine, a newer one, which acts on the melatonergic system. Pregabalin is more an anxiolytic, which also can be helpful and can have a sedating effect. So these are options for patients who suffer from tinnitus plus insomnia plus depression. Quetiapine would be also a drug which is categorized as an antipsychotic drug, but it also has antidepressant effects, and it also helps to provide a distance to the worries, and also to the distance to the sound, also has a sedating effect. So you have a broad choice, and that's just a selection of some medication. I would recommend to everybody who has to do this, because there's no psychiatrist involved, to really limit your experience to some medications, that you get some feeling for the medication. You should not use 20 different medications, then it's you get no real feeling for it. So I would start with 2 and 3, and when you get a feeling for that, you can use it for various patients. And then you go to the activating side. Now, this is mainly for patients who are primarily depressed or anxious, but do not suffer from insomnia. So the standard is a selective serotonin reuptake inhibitor, what we say SSRI. Escitalopram is a standard medication, sertraline another one, which has been used a lot in tinnitus patients, also in clinical trials. And additionally, there's an option to use SNRI. These are the serotonergic, noradrenergic reuptake inhibitors. The most known is venlafaxine, and so in the US it's called also Effexor and duloxetine. So you have various possibilities, and also there's a possibility to combine an activating medication in the morning and a sedating medication in the evening. So it's not rocket science. Just choose 2 or 3 of those. Let's say escitalopram for the activating, trimipramine, mirtazapine for the sedating, and make your experience. And you can also treat tinnitus patients with some comorbid depressive symptoms. I also have to talk about benzodiazepines, for example, lorazepam, alprazolam, clonazepam, because it's a drug which has pros and cons. And the pro is we have some studies that have demonstrated that with benzodiazepines, you really can reduce the tinnitus percept, so the tinnitus gets reduces some of its intensity. You can reduce anxiety. They have a sedating effect, so you can treat insomnia, and the benzodiazepines act fast. So the typical antidepressants, they take some time to have an effect. Benzodiazepines act fast. But, and the big problem is they all have a risk of dependencies. You can use to it, they lose the effect. You have to increase the dosage. So all the different aspects of dependency, and it's very difficult to get rid of them. So you should be aware. So they are very efficient drugs, very good drugs for the emergency. So in case that somebody is really desperate and can't stand it anymore and is suicidal, benzodiazepines are the drugs of choice. But it becomes more difficult in the long-term situation. Then you have to be aware of the risk of dependency. So I already come to the end, and just to summarize some general therapeutic suggestions for the management of psychiatric comorbidities. You should care for your patient. You should establish a therapeutic relationship, and the patient should leave your office with the feeling that the patient can tell you the truth also about suicidal concerns, about his or her worries, and you will be able to handle it. So I think it should be a relationship that the patient feels I am taken serious and I can tell what really bothers me, what concerns me, and there's somebody who takes care for me. Offer what you can offer. I think we have all to be aware that there's no possibility to cure the tinnitus, but we can lower the burden of tinnitus by efficiently treating the psychiatric comorbidities. And this is something we have to explain to the patient. We have to explain to the patient that the tinnitus probably will last, but we can help the patient to get more distance, to get more control again over his or her life. And the tinnitus will not be so intrusive anymore, not so present anymore. That's what I told you already. Yeah, I think we should be clear and honest. We should be clear about our limitations, so the patient should know what he or she can expect and what not. You should always think about psychiatric comorbidities. There are sometimes more than just a comorbid depression or an anxiety disorder. A typical example is sometimes over time you find out that patients have always the same tinnitus, but sometimes they are really severely depressed and sometimes they are not concerned by it and are euphoric, and they might suffer from a bipolar disorder, which is probably unrelated to the tinnitus. So the patient typically tend to attribute their suffering to the tinnitus, but there also might be completely different reasons for that. So try to be aware of the situation. Most important, as mentioned several times, try to offer a therapeutic relationship, an open relationship, and to be a reliable partner on the way to deal with the tinnitus. So the patient should know that in case that they are desperate, they always can come back and tell you honestly what is their situation and how desperate they are. So for us, it's also important just to stand the situation, because for sure it's not so easy for a medical doctor. You have a patient who is suffering. I have no cure for the patient, but the worst thing is if I send him away. So it's important that we tell him, look, our possibilities are limited, but you can always come and we try together to find a good way for the situation. And I think it's very, very important to transmit hope. We all know the desperate tinnitus patient very early after getting the tinnitus, they want to get rid of the tinnitus, but they have to realize, no, it won't be possible that they get rid of the tinnitus. But we can tell the patient that tinnitus is not a malignant disease, and that almost all patients find a way to gain back control over their life. And I heard a very nice metaphor of one of my colleagues recently, who mentioned in the beginning, it looked like that the tinnitus was on the wheel of the car. So if the car is the person, so the tinnitus determined where life is going. And so the first goal was to get the tinnitus back from the wheel of the car to get to the next seat. And then at a certain time, you tried that even if you have tinnitus with you, that he has no control anymore over your life, and there's somewhere on the back seat or in the completely in the back of the car. So it's still there, but the tinnitus is not controlling life anymore. And I think that's a perspective that you can give every single tinnitus patient. I think especially in the desperate situation, this is very helpful for the patient. And now I'm ready and for sure open for questions.